Mhm. Good afternoon, everybody. Can everybody hear me?
I can hear you. You're good.
Okay. I don't think anybody else can. Is there somebody who is linked on can let me know if they can hear me? Myself and Kofi can hear me, but I'm not sure everybody else can. Okay, excellent. I got one response. That's great. I'm going to start. I might be a little early. People can come on as they sign in. Once I enter into my presentation, I'm going to try to share my PowerPoint. And if it doesn't work, I'll leave that to one side and just go ahead with my presentation. So to start, I want to start with the Newfoundland Labrador land acknowledgement. Second. We respectfully acknowledge the lands on which we gather as ancestral homeland of traditional Mi'kmaq territory. We acknowledge that the lands and waters on which we gather are the homelands of the Innu and Inuit of Labrador and recognize their ancestral and continued ties to these lands and waters. We acknowledge with respect to the diverse histories and cultures of the Beothuk, Mi'kmaq, Innu and Inuit of the province. We strive for respectful relationships with all people of this province as we search for collective healing and true reconciliation while we honor and protect this beautiful land together. So if there's anybody who can't hear me, just stick up their hand or let me know one way or the other, or if not, I'm just going to continue on. I'm going to try and share my PowerPoint once. And if it doesn't work, is anybody able to see my PowerPoint? Oh, excellent. I'm having some technical difficulties and I managed a certain amount and I don't want to change anything in case I lose the whole words. So I lose you, but can you see my PowerPoint?
Yes, we can.
Okay, thank you. So I'll start with the session that you're joining now is drug treatment court screening. And should urine drug screens be observed or unobserved? And how do you balance the impetus for court monitoring versus clinical best practice in addictions with UDTs and trauma-informed care? So I'll start by introducing myself. I'm Valerie Corcoran. I'm the Drug Treatment Court Provincial Manager in Newfoundland and Labrador. And I'm also a member of the Drug Treatment Court team in St. John's and a member of the treatment team in St. John's. So a little bit of history with our court. We were established in 2018. We took on our first participants in 2019. And as with most drug treatment courts, we are team-based and we take a non-adversarial approach to our court. At any given time, we average 8 to 10 active participants. Sometimes we've been as low as 4 or 5. Other times we're as high as 14 or 15. But we tend to average and work best when we're around 8 to 10 active participants. One of the things that we are we started out as, and we were slightly different in some ways of other drug treatment courts, is we're a trauma-informed and harm reduction approach. And as I go through the presentation, I'll touch a little bit more on how each of those perspectives have been incorporated into our court. So we do, given the topic that should drug screens be observed or not, and the fact that we do unobserved or monitored drug screens, I wanted to reassure everybody that we still keep to the protocols. We do our drug screens randomly and weekly. We use rapid on-site testing at Drug Treatment Court Services, which is our therapeutic center, let's say. We use our drug screens as a component of treatment rather than to monitor compliance in any way. And again, it's not witnessed or observed, and everybody's name keeps changing for that. But we do not use an observed method of testing. So how did we get here? I thought when I was looking at doing this presentation to go, how did we go from what is usually a standard of observed drug screening to monitored drug screens and what that actually means, and how did we integrate it into our therapeutic approach? So when we originally started back in 2019, we started with observed drug screens because we were in partnership with our St. John's Opioid Treatment Center, which is part of the Eastern Health Authority at the time. They used lab screening, which meant every drug screen was run as a lab test. There was no rapid testing available at the time for the purpose that we needed. The lab tests were very sensitive. They tested for a wide range of drug use and other issues that the participants may be presenting with. The participants integrated into the opioid treatment center drug screening process and protocols, and it also meant that they had extra meetings with the opioid treatment staff. So what happened with everybody? It was COVID. Why did we change from the observed drug screens that the health authority was using to what we use today? So first, we started having some issues slightly before COVID, but they were really exaggerated during and after COVID. Mostly because of all the pressures and focus on the health authorities, their processes and administration of the testing changed. We went from having our clients integrated into the opioid treatment center protocols into having them partner or work with a nurse practitioner and paying attention to all their administrative protocols around drug testing. What also happened as a result of that and a result of the backlog of tests during COVID, we had a lot of difficulty getting timely results that we could actually use in drug treatment court or in our treatment process. Our lab results were delayed 2 or 3 days. We could manage because we were seeing our participants weekly or more than we were seeing them twice a week at that time for counseling and in court. But our lab test results started to be delayed by a week, 2 weeks, 4 weeks, 5 weeks. And for anybody who's in a drug treatment court, you know how that would restrict how you could respond to anything that was going on with any of the participants. So it really limited how we could respond to any changes in drug use, whether the person was presenting with positive drug screens or negative drug screens. So as we tried to resolve those issues and they just became onerous, what we decided was to evaluate our drug screening, what our purpose for our drug screening was, and what process we would end up using. So, of course, we looked at, I have to go back to the original requirements for a drug court, and that it's essential for both treatment and case management for, tracking whether or not a person is using, what they're using, a whole pile of issues, and it was a required component, so we couldn't eliminate it altogether even if we wanted to. We didn't want to, but we could not eliminate it. So then we looked at the drug testing is used as a clinical tool, and it's really about encouraging honesty in reporting drug use and to support progress in addressing drug use and their case management issues. We also were aware of, cheating and beating. The drug testing systems were, and hints around it were wildly available and known amongst the participants, and they'd be talking back and forth about them. And we were looking at, was there a way we could really reduce a participant's need or desire to alter or cheat the drug testing system that we were using? So then we needed to look at how to use a drug collection system that would strike that balance between trusting clients and ensuring that the results were not contaminated or falsified or tampered in any way. So then we met as a team. So most of our changes and discussions around our protocols are done with our drug treatment court team. So that is our judge, our federal and provincial crowns, our defense lawyers, treatment provider, our addiction specialist, and myself. And we had a meeting to discuss really what was the purpose of our drug screening? Like, what really was the need to have drug screening and having the results presented in court. And so we decided that the purpose was to track progress. Um, and did we need then to have observed drug screens to ensure they were valid? So I'm sure everybody probably knows what an observed drug screen is. You're actually physically in the room when the person is providing the sample, and you're observing to make sure that they're not tampering or altering the drug sample or the urine sample in any way. There are, a variety of methods that people could stand behind the person who was providing the sample. They could use mirrors. They could, watch through a window. There was all sorts of things. And our question was, did we really need to have observed drug screens to ensure that they were valid for our uses for drug treatment court? So then our next thing became some very practical concerns. And the main one was staffing issues. We're a small drug treatment court services, there's two of us. We would need same sex observers, which means we would have to either hire a male or figure out some other way to accommodate that protocol, and we could not do it. The second practical concern we had was comfort issues with the participants. How did they really feel about observed drug screens? And that was a interesting question to get them to talk about, because many of them are used to the drug screening within correctional facilities, within prisons, within drug programs, within methadone and Suboxone programs, where they were always observed, and in health, any kind of drug related programs. Where testing was involved in health services, they were used to observe drug screens. So we had to talk to them about how they really felt about that. And most of them, as I get in further, they were so used to having their boundaries and everything just non-existent that they were like, yeah, well, I'll do it because I have to. The second one became another interesting conversation was how would the staff, our staff then, who would now be trained in delivering the drug screening, really feel about having to observe screens? So I put my own personal twist in there because I don't come from a health background. And I found that the possibility, because we did the training for it, but the possibility of having to do observed drug screens was really uncomfortable and undignified in my eyes. So then the question was, how can we balance all of that and make sure we were getting what we need out of our drug screens? Um, And then we looked at, we really, we push a lot in terms of the fact that we're a trauma informed harm reduction approach to our drug treatment court. And we wanted to look at how did observed screens really fit into that perspective? Why was it required if we're looking at things from a trauma-informed and harm reduction perspective. What was to be gained from that, and what would we lose if we didn't do that? We're also aware of it really, for us, we were comparing it to any other urine drug screening that is done within the health authority. And it's really, unless it's drug use related, it's not required for any other lab or urine testing. Or as I'm quite known for saying, I don't have to have somebody in if I've got to go in for a urine test for diabetes or anything else like that. So why are we making this? What really is the purpose for imposing it on our participants? So then we were talking about how that perception then is really an automatic distrust of our participants. We are on one hand trying to develop therapeutic rapport with our clients, to maintain therapeutic relationships with them. And then we're saying, but in this element of why you're in drug treatment court and what you're doing, this condition, we don't trust you. So we have to watch you. So our approach was then, can we switch it to an approach of trust first and address any issues that come from using non-observed drug screening later? So we don't punish people for using. So that was another one of our questions. So why are we concerned with about watching people during screening? Like, why is it what is to be gained uh, from direct observation? Is it, if it's people are going to try to fool the system or fool the drug screen, well, really, that's a therapeutic issue. If they are, altering it, again, that's a therapeutic issue. So it was less important for us to do the observed piece and focus more on why a person might want to alter. Is there a way that we can instill some of that trust up front so that their idea of I need to, alter a drug screen, or I need to prove something different, or I need to fool. A lot of the background was coming from, I need to set up this challenge and I'll fool this test. And then really what we would set up is people not being honest about their drug use and honest about what was going on. So we decided we'd use the trauma-informed approach and say that services, including our drug screening, are provided in ways that recognize the need for physical and emotional safety for our participants. Um, I think our participants, a lot of times, because they are classed into categories of high risk, high need. They've had a lot of experience in the system. They've had a lot of experience, um, you know, being dismissed from other programs. That the trauma, looking at them as a vulnerable population or from a trauma approach was, um, it took a little bit of training in our team to start doing that. And then I have to say, our whole team clicked into that. And then we started to look at what impact did direct observation of drugs, of urine sampling have on the participants. And, we recognize and acknowledge and talk a lot about many of our participants have histories of abuse and trauma. So, having somebody observe them in a washroom can be re-traumatizing, can be, undignified to a lot of them. And, I came from a history of working within institutions, and uh, more than one of the people that I worked with were punished for what they used to call shy bladder. I can't do this. So then it was automatically seen as a means of deceiving the system, as opposed to, could it really be somebody who had a lot of anxiety around somebody observing them use the washroom. Many of our clients are very used to having their boundaries ignored. So when we first started talking to them about it, it became, I don't care, you can watch me, you can do whatever. But then it was like, that's really an indication of my dignity and my boundaries and that have been pushed to this through this process that I don't even have to care about it anymore. And as we talked to them more and more about it, they were like, yeah, and then there's times when I have difficulty and, then I'm going to be failed in my drug test or I'm going to have a punishment or a sanction because I can't produce a sample. And it was like, we didn't want that built into our process either. And then the other and the main one was balancing the perception of mistrust. So when you are working and establishing a therapeutic rapport with participants, and then you're starting off drug screens from a perception of mistrust, like we don't trust you enough not to follow through with this process in the way that we are presenting it, then the message that we're really providing is that we mistrust you too. And then that's a lot harder to balance with the therapeutic alliance that we have with clients than if we start off with a position of trust. So then the other piece was how do we do this when we're a small staff? And so now we have the treatment staff are actually going to be doing the drug screening too. And we spent time working on and developing a way to integrate the treatment and counseling with the drug screening. So it is um, taken from the approach that the goal is to increase the therapeutic relationship with participants as opposed to setting up a adversarial I'm using you're not or anything like that. So it was all in the way we presented it to the participants too, that it's used as to support the changes they are trying to make and to encourage honesty in the reporting rather than I have to hide that I'm using. And it's done as a part of right from the start. It's introduced to the participants as an integrated process where you have conversations about your drug screening with the person that you are uh, doing counseling with and looked at what are the issues around what the outcomes of your test. Let's say whether it's if it's a negative test and what has happened that you can keep this up, or if it's a positive test, what are the things that are impacting your having a positive test. Um, and the other thing that we get, but when I say all of this, like we often get when people are starting court going, how will you know that I am not, altering the test and, I could do this and I could do that. And it's like, yes, you can. You can do all of that, but it's only one element that we use when we are noticing what's going on with our participants. And so, if we have somebody who is testing negative, but they look, and I put that in brackets, like they're using, so they look disheveled, they're, having a hard time showing up for everything. They are, giving other indications that they're using, but all their tests are positive. Then we'll start engaging the health system and saying, obviously, there's something else going on because you're not using, but your health and your physical appearance and everything is not improving if like somebody who hasn't been using. Um, and what we find is the clients will say that, or the participants will say that themselves, right? Like, I'm not doing really well. I may not test positive, but I'm really not doing well. What else can we look at? And, because the two of us who are involved in the treatment part of it have a lot of experience with people who have been drug using, there we pay attention to all the indicators too, of um, how are they doing physically, emotionally, how are they doing with we also, lots of times we have people who are supporting them who are talking to us about how they are doing. So we look at it as from a holistic perspective, not just a drug screen perspective. The clients or the participants can also use the screen results just as they strive to meet their goals. And I put that in there because as they get used to the process that we use, also that we're not punishing them for drug use, that we're using them in very positive ways in their lives, then they start using them to help set their goals. So we have, you know, them say, well, I'm having a lot of difficulty, but I'm going to try this weekend. So when I come in next week for the test, whenever it is, I'll see how I can do. And so they're adjusting their drug use behavior around their goal of having a negative drug screen. And it works out much better than I'm explaining it, because they're not looking to manipulate it. They're looking to say, well, if I can do this, is it possible that my drug screen will come out negative next week? Um, we also, when I introduced our court to say that we have 8 or 10 active participants at a time. So what that also lets us do is know our participants quite well. When we introduced our drug screening into our therapeutic process, we see our participants a minimum 3 times a week: court, drug screening, and counseling, and sometimes more often. So quite often we're very aware of what's going on with them and when they're having issues. So the drug screens is really like a support or a backup to that. Um, and they quite often will come in. I always use the example of people who will come in and say, I had a rough weekend, but I don't know if my tests are going to show that I was using. And then their tests show that their tests come back negative. And then we're rewarding them for the holistic honesty about their drug use, because they are aware that the drug screen may not support the fact that they had been using on the weekend. So they're actually upfront about what's going on, which again is what we're looking for when we're doing our drug screens. So what is our approach? So I looked it up. People used to call it monitored drug screening, so we just call it unobserved. And we started from a position of awareness and trust. And what that means is we anticipate that people are going to test positive, and we tell them that. And we're trying to get them comfortable with the fact that they are not going to be sanctioned or punished if they test positive. So the trust is, give us your drug screen, give us your drug test. We're trusting that you're going to enter into this process in a way that is helpful to you. We do have all the set protocols and everything in place around our drug screening. They sign consents. The process is fully explain to them, that they come in and they follow a set protocol. So they come into our office, they have a chat with whoever's doing their drug screen, usually it's Kara, that day. And they'll talk about what's been going on. It's a few minutes check in. They're not allowed to take anything into the washroom or anything with them. So, we don't do clothing checks or anything. That's in another on one of my other slides, but they don't do any kind of check to say, we don't trust that you're going to go in and give us a sample that we can use. They're supervised in that, we're here. We see them go into the washroom. We see them come out of the washroom, but that's the most that we do. We are not doing it without standards behind us. Our staff are trained and certified. We use a 12-panel drug screen cup, urine cup. We also use 2 dips if we need for additional drugs. So, they are standardized testing procedures that we use. We just don't observe the participants providing the samples. The screening is done by our addiction specialist, who is our primary treatment provider. And we do that because sometimes we have to switch around. If she's off, I'll also do the drug screening. But to the best of our ability, we keep it to the person that is providing the treatment for the particular participant. And we think that the process that we're doing reinforces the concept that it is a component of the therapeutic intervention, not a monitoring of the therapeutic intervention or a monitoring of their progress in the court. It's really, how can we use this whole process in a supportive, positive way? So here goes our testing process. There's conversation before and after the test. All told, takes maybe 15 minutes. They come in, they check in, they have a quick chat, then they're given the testing cup. We in that first 5 minutes or so, sometimes it's longer, depending on what's going on in the participant's world. It's really a conversation about, what's likely to happen. How have you been this week? Do you think, if people who are using, what have they been using? If they not, have they had any issues? And it's done in a non-confrontational, supportive way. Then we don't do any kind of body searches or anything like that. They are not allowed to take things into the washroom with them. The test takes about 5 minutes. The results are available on the spot, basically. The participants are there when we get when the results are presented. We let them see the cup. We talk about the results of the drug test. And then if, they talked about coming in, I don't think I've been, or nothing's going to show up and something did, then there's a conversation around what's likely to have happened at that. Um, happened, and it depends on their conversations around that about how much we address that in court the next time around. We did find, I'll go back to our observed testing and our lab testing with the health authority. We were never able to respond immediately to any of the drug screen results because we were waiting days to have them. So then some people would be like, I don't know what happened. I don't remember that. Or, or, um, well, I was there and they sent me away, so I didn't get to do my drug screen or anything. So we took it out of a totally monitored, confrontational in some ways process and brought it into the therapeutic atmosphere that we try to maintain. Um, Before I get into that, well, maybe I'll do it with the less issues with tampering. After the first few weeks, the participants get used to what we're talking about and understand the therapeutic approach to the drug screening, and that we don't need to observe them because we are trusting in what they say to us when they're coming in for the drug screen. And if there's any discrepancy, that we address the discrepancy, not the altering or tampering or anything of the um, drug drug tests. So I say we have, because I monitor a lot of the processes to see if we need to change them. The things that I noticed is there's less issues with tampering and altering. I think we have no idea what was happening when people were down at the opioid treatment center because we weren't getting that kind of feedback. But in the course that we have doing it on our own since 2020, 2021, we've only had one person tamper. Um, and his circumstances made it understandable in that he was doing really well, and he was afraid that he was going to test positive because he was using, but it was a number of days before. So rather than talk about that, he tried to alter the test. And it was figured out, or we detected it, because he tested positive for a drug that he never used. So then the question was, how come this is showing up? And then he had to talk about, well, I really tried to alter the test because I was afraid of this. And we all, including him, had a little bit of I call it a giggle about it, because it was about, be careful what you're doing, because even in altering the test, you put yourself in a bad light. And so then we addressed it in the court as a therapeutic issue, how to be honest about your drug use, and even when you're doing really well, that you may be having some difficulties, and that, you might be using, because that's what we want to address in the therapeutic intervention. And we gave him a sanction for being, for altering the test. There wasn't a need to dismiss him or anything like that, because it really was, once we knew the context of what was going on, we were able to address that. We have not been aware of any other issues with tampering or altering the drug test since then. Our test cups are sensitive to any altering of adding liquids or changing liquids or anything like that. And so we've not had anything where we could say, like, we have a number of people who are tampering with the tests. We also have less issues with questioning the results because they're immediate, whereas before with the lab results from Eastern Health, they would be a couple of weeks back and they'd be saying, well, it's changed since then or whatever. So uh, they don't question the results. And if they do, we allow them a second test either that day or the next day. And most of the times, again, it's around I'm having difficulty talking about my drug use rather than, oh, these tests are inaccurate or anything like that. We also have less issues with people skipping the drug screens because they think they're going to be coming back positive. What we do have is people who are missing drug screens because of the whole issues that are going on in their lives, and then we address that as opposed to I'm skipping the drug screens because I might be using. And we engage more with the therapeutic process and drug screening combined. Um, that takes time. I think that's the thing that kind of impacts using the type of screening that we do and the way we use it is not a quick process. It takes time for people to get used to it. It takes time for people to be honest about their drug use and continue to be honest. It takes time to, to have that 15 minutes of in when they're coming into the um, for the drug screens to engage with them. But that's really what we're looking at. We're looking at building that rapport and relationship and keeping it up over time and having that the drug screens complement that rather than running a little bit against it in some ways. Some of the other positive things we've had is we've had participants ask for extra drug screens as a means of enhancing their progress. And what I mean by that is we've had two kind of groups fall in there. People who are doing really well in their progress and in their goals, and they want to keep it up. So they will ask to do an extra drug screen a week in order to, for lack of a better way, prove to themselves and others that they are really doing what they're saying they're doing. So we accommodate that. And the other is participants who are continuing using and having difficulty. They will say, maybe if I do 2 drug screens a week, I can get around, then I can't use because I'm going to have a drug screen on Monday and then another one the next, a couple of days later. And they can use the drug screen process to help motivate them to see if they can address their drug use. And that has worked really well when people have done that. They don't necessarily keep it up for the whole time they're in drug treatment court, but they keep it up for a period of time so that they are actually engaging that process in addressing the drug use through their therapeutic interventions. Um, you know, because we couldn't accommodate that when we were partnered with the Opioid Treatment Center, but we can accommodate it in the drug screening process that we use now. And to me, it also speaks to the comfort that the clients and the participants have about the whole process that we use. So then the question is, how do we measure success? If we're not just using the drug screens as, the positive and negative and, ensuring that everything is done the way that is valid in other people's eyes. Well, we look at it from a holistic perspective. We have, in the course of people's time in drug treatment court, has there been a reduction or an elimination of charges or new charges? The reduction or elimination of problematic drug use. Notice the reduction, not the elimination. So they don't have to have like 3 or 4 months of total negative drug screens in order for their participation to be considered a success. We look for reduction over time and sustained over time. And for some, the goal is total elimination of their drug use. Enhanced community supports and connections. Again, most of our clients come in with very few community supports and connections. And that's another one of our measurements that we use. Like, how have they enhanced the number of people they are connected to, and the supports that they can use once they're finished drug treatment court. Improvement in health related issues. And I'll go back to what I said about when people are coming in and they're testing negative, but their health is still in awful, deplorable states, and what we're doing is helping them address them also. Most of them are disconnected from the health systems. And so we look at improvement in their health related issue as a piece of the success. Um, and they see it as that also. And the last one I have is improvement in housing and the living arrangements, and we call that improvement in community stability. What have they come in drug treatment court in terms of housing and stability, and how are they leaving drug treatment court at the end in terms of housing and stability? So it's the piece of unobserved drug screening started to look at it from how do we do drug screening from a therapeutic point of view? How do we integrate that therapeutic point of view into all of the requirements of our drug court? And then does it really end up with us measuring success the way we want to do it? And so far, I have to say yes. I doubt we'll ever return to an observed method of drug screening, because people can't convince us why it is necessary, I guess is a good way to say it. Um, I didn't go into in detail a lot of the processes of how we make sure that the testing is valid, and how we, our exact protocols that we use when people come in, but we do have a lot of checks and balances in place for that. And our whole team accept what we have done. And that's the other really positive thing. Like, we started off with a very stringent look at our drug screens, and needing the validity of observed drug screens and the lab tests, and making sure everybody showed up and on time. And we've moved it away from that into a more integrated component of our therapeutic process. And the language that everybody uses in our team meetings is around that, which to me speaks to the whole success of what we have been doing. So that is, if I can exit out of this is the end of my presentation. I'm not sure I'm going to be able to exit without. So, is there any questions? I'm a little bit of everything, so I'm trying to. Oh, so one of the questions that we have is, how do you manage an individual whose primary substance is opiates, but they require opiates for pain management? Are you able to test for levels? No, we don't. So what we do rely on is if people have prescriptions that they are um, following the prescriptions as required, like if their primary substance of misuse is an opiate, and they're uh, engaged in using opiates for pain management, then it's kind of integrating with their health um, provider to see how we can have that work. I don't know the best way that I can say it, have that work for them. Most often what we see is a misuse of things like Ritalin or benzos, and we do the same thing. And we rely on a number of indicators to make sure that they are taking their prescriptions as required. And quite often that comes out through the discussions that we have with our participants as opposed to monitoring their levels. We started originally monitoring levels, and then we thought we don't even know what we're talking about. None of us on our team are health providers. So then we started looking at, is it positive or negative, and what are they using? And what is the goal that they are setting for themselves in terms of changing or eliminating their drug use? I'm not sure if that answers your question, Jen. If not, are there any other questions or any other concerns from, wait, no, okay. So the next one is, what are your thoughts about the best practice standards that recommend witnessed drug tests? I got to go back to what is witnessed. Like observed is if you're standing over somebody. Witnessed is another process that, that's a term process that people use, and ours is the standard of unobserved. And we find that it fits into that best practice standard because we're looking at um, the process as a whole, not just whether or not they need to be witnessed or observed. Um, we don't sanction people for positive drug tests. When participants demonstrate psychosocial stability for a period of time, to the positive result. What we look at is, are they honest about their returning to use? What is going on? And we give people time. Like that's the other thing. None of our sanctions are necessarily got to do that today or jump on them for having a positive drug test. When they come back positive, we're talking about what is going on. And then uh, in the court, the team and the judge basically will say, we noticed that you've been having some difficulty. Hopefully you can get things back on track, speak to engage in your treatment, and let's see where we can progress from there. Um, so there's no sanction basically for any type of drug use. Does that answer your question? It is, it took us a while to get used to the concept that we didn't need to observe people. And we, I'm going to say we trust first and deal with anything that doesn't fall into that category as we move along. So, if somebody, lots of times people will come in and they'll talk about, how will you know that I'm not altering it? And our next question will be, why do you need to alter it? And so we quite often get that approach from people who have just come out of prison and they are suspicious of our methods. And then when they realize that we're building it into their treatment plans as opposed to questioning their ability to alter a test, then they stop with that and they start engaging in it as I see I see the how this is working for me also. I will go back to, I think maybe part of why we worked hard to make the unobserved drug screening work is because from health we're not health providers. Like we're not nurses, we're not nurse practitioners, the staff that worked at the opioid treatment center. So there is that, I have that boundary around me about observing somebody else produce a sample for drug testing. Um, so then we built it from there about how can we change it to make sure we're meeting our drug court needs, but without having to violate that boundary of the person. And now there's a number of people who are in our court who are on Suboxone and methadone. They are also being drug tested by their providers, and they are observed during that. And that's like, well, that's the process that you're involved in, but drug treatment court doesn't do that. Um, and so far we're 2.5 years into this, and we have found that, it works for us. One of the other things we are in the process of trying is oral drug screens, which will eliminate that process altogether. So have you explored saliva drug testing? Yes. Um, we have recently purchased them for our drug treatment court to reduce the mentioned issues with discomfort of witness screens and so on. And we have used them. We've tested them on and off. We have them hopefully going to be rolled out with our new as a test to with our new newly implemented drug courts that are coming on in Corner Brook and in Grand Falls. And then we would use the urine drug screens as a backup. Um, there's some difference with the saliva drug screens. It's like sticking a popsicle stick in your cheek for a couple of minutes until there's enough saliva produced to read them. But it eliminates the whole process of witnessed and observed drug screens. The question we have is, does it test the oral drug screens that are available, test all the drugs that we um, need to be testing for in Newfoundland? So far, we have been able to get the pre-made ones that do that. Um, the unfortunate part, I try stuff on my own. I tell a joke about it that I decided one day I was going to try the oral drug screen as a test, but I didn't pay attention to what I was doing, and I tested positive for a wide variety of drugs that I never even heard of. But then when I looked at the drug screen, I didn't follow the proper procedure and I didn't allow enough time to produce the proper amount of saliva. So the control strip came up altered. It didn't work. Um, but anyway, as we get into using them more, I can see us moving away from the urine drug screens, except for either exceptional cases or as a backup. So the oral drug screen is not reading properly, or we're questioning it, so we'll back it up with a urine drug screen. Yes, there are sanctions for dishonesty. And what are the sanctions? Our sanctions are depends on where the person is in terms of the process of the court. And our team meet before drug treatment court every week, and we discuss what's going on with our participants. If they're dishonest, our typical response is a Friday morning appearance in front of our judge, separate from drug treatment court. It's usually 5 minutes, and quite often then that is one of two things is happening when the judge meets with the participant. Um, it is a reminder, that you're in drug treatment court and the conditions are you be honest and work with the treatment team in order to address that issue. Or there's a more in-depth conversation with the participant about what's going on, and then it actually turns into like a therapeutic sanction. Um, if there's repeated dishonesty and a lot of um, lack of engagement, I'm going to say, in all the processes, then we hold what we call as a continuation hearing, which is a sanction, and that's a review of the person's participation in the court. And from that, we design whether or not it's called the conditions for which a participant has to continue, and or if they aren't engaging in that, we will dismiss them. But that tends to be our like the dishonesty is dealt with therapeutically and with a court sanction, but we don't use a variety of sanctions. That's the typical one is caution from the judge in court, comments from the judge or crown in court. Um, comments or people usually are aware that they're going to head into a sanction by our treatment team. This is going to be addressed in court, and then a Friday appearance where they are reminded of of their requirements for drug treatment court. We have it built into our budget. The testing is so while we are paying for is the testing cups and or the oral drug screens, they run us about I don't know, $3,000 a year. I wouldn't quote me on that. They're about $5.99 to $6.99 per test. And when you look at our numbers, then you can see that manageable within the budget that we have. We can't hire outside companies to do the testing. That was way beyond what our drug treatment court funding would cover. And while we were getting the free testing from the opioid treatment center, it really wasn't fitting into our needs. I'll read it out. In some cases, the urine test can help a client realize there are drugs in their system that were not expected. For example, fentanyl. It can be used to try and prevent drug toxicity issues, but if there are drug testing supports outside of drug treatment court, perhaps it's not needed in drug treatment court. We also do that. We've had a number of people test positive for drugs that they were unaware of. So that a usual example is somebody who's an opiate user suddenly is not using, suddenly showing for cocaine. So they could be reverting to cocaine use, or they're using tainted weed. So our thing is, again, what's going on. So often they'll say, well, my dealer must be cutting my weed with fentanyl. And our thing is, we go in through how dangerous that is, and then the recommendation and the requirement is that they purchase their weed or whatever through the commercial businesses that provide that. If it's an ongoing issue, then we start addressing that as an ongoing issue. But it can, some people are really shocked when they see that, they're testing positive for other drugs, but aren't aware that their drug supplies are tainted. But hopefully, like, the whole process helps them in a way that makes our drug court makes it more therapeutic and less punitive. Because they've been quite used to the punitive processes that they've been involved with. We've had positive reports back from the participants on it. Our team hasn't questioned it or had issues with it. The main feedback that we got from the crowns, and that was, now we see everything right away. We have, and we can respond positively too. Like, when people are putting an effort in and changing their drug use, and we weren't finding out for 4 or 5 weeks that they were testing negative, then they're not getting the immediate feedback that they need. Whereas with the screening that we do now, it's immediate. And sometimes we're dealing with the issue the day that the drug testing is going on, and other times it's put off to be managed within the next court appearance. And the most comments that we have with the new people coming in is like, oh yeah, right, because they are used to the observed drug screening, and then they kind of click in that they don't need to be engaged in any kind of opportunity to manipulate the system because we don't pay attention to it, is the best way to say it. My I mean, I don't think I need to make too many changes to my um slideshow that will be copied and made available to everybody. And if you have any questions, I don't have my, I'm with the drug treatment court in Newfoundland, and my email is valeriecorcoran@gov.nl.ca, and I can put that into the PDF of the screen. So if anybody has any further questions, they can pop me a line. And hopefully other people will, bear in mind the impact of what observed drug screening does to an individual and see if they can adjust that process to be on a more therapeutic lens within our drug treatment courts. So if there are no other questions, we're done. The next session is, I have to look it up, the use of risk, need, responsivity approaches in drug treatment courts, and it starts in a couple of minutes. So I will sign off, and if anybody has any questions, they can contact me directly. Thank you, everybody, for coming. Hope to see you in the next sessions.